Our next speaker is Dr. Devendra Maheshwari, who is again a senior medical consultant, glaucoma services at Arvind Eye Hospital, Tirunelveli. And he is going to talk on something very important: micropulse transscleral photocoagulation and cyclodestructive procedures. On to you, Dr. Devendra.
Yeah, good evening, everyone, and thank you, Chitra Madam and ARC team, for giving this opportunity. So today I'm going to talk about the micropulse transscleral cytophotocoagulation and cyclodestructive procedure. As all we know that traditionally glaucoma management start with the medical treatment. If fails, we consider surgical option, and cyclodestructive procedure considered at the last choice. With the newer modalities like the micropulse and ECP increasing used in the moderate to advanced glaucoma with good eye visions. So the cyclodestruction has a long history, started long back in 1930. The cyclotherapy and diathermy has been used long back in the past, but it has been discontinued because of various complications and the adverse effect. So currently used cyclodestructive procedure are diode CPC, micropulse, and endoscopic CPC. Coming to the high intensity ultrasound cytophotocoagulation, this is the method in which the circular probe has been used to produce a thermal necrosis by using an ultrasound energy. It's a novel method, but it does not depend on the pigmentation of the ciliary body. However, there's a few clinical studies has shown good outcome, but still there's a long-term prospective and randomized control study are needed to come into the clinical practice. Coming to the endocytophotocoagulation, it is a selective ablation of aqueous producing ciliary process via the ab interno approach. In this procedure, this ECB probe contains the diode endolaser, aiming beam, light source, and endoscope, which allows us to control ablation of the ciliary process. It can be done either by the limbal or the pass-pen approach. This procedure is suitable for the patient who has a thin sclera, ectasia, especially pseudophakic and aphakic cases. However, the fewer studies have shown the CPC has a good outcome and combined with phacoemulsification, but still this no randomized prospective studies are comparing the ECP with conventional cytophotocoagulation and ECP. Apart from that, the CPC always, endoscopic CPC always associated with the high post-operative complication like severe inflammation, cystoid macular edema, and the vision loss. So most commonly used transscleral diode cytophotocoagulation are continuous wave CPC and micropulse. So what are the indications for this procedure, especially neovascular traumatic and aphakic glaucoma not responding to conventional treatment, and the glaucoma following the penetrating keratoplasty and post-VR surgery like silicon emulsified glaucoma, post-buccal glaucoma, and the eyes who had underwent the multiple trabeculectomies and they have the history of the GDD, still IOP is high. Apart from that, in the recent time, there's a development of the new laser like the micropulse. These micropulse can be used in the moderate glaucoma with useful good vision. How it works? The diode laser is applied to the ciliary body and that destroy the ciliary epithelium and reduce the vascular perfusion, thus reducing the ocular production and reduce the IOP. So coming to the continuous wave diode cytophotocoagulation, this is the machine console, and this diode laser is delivered through the fiber optic handpiece. By that, this is called the G probe, and this is the foot plate. This procedure can be done either in the block room or in the operating room. We used to do in the operating room, and the setting has to be recommended, has to keep low and slow. So keep the power around 1200 to 1500 milliwatt and duration around that 3000 millisecond. So this is a surgical video. So after having the perivulvar retrobulbar block, this the G probe has to keep at the limbus. When giving the second spot, we have to keep in mind the probe edge has to keep the halfway of the first spot. And few things we have to remember that there should be the gentle pressure has to be applied. So little firm pressure through the globe. And apart from we have to keep in mind we should avoid the pop sound. Pop sound is the indication of the excessive energy is used. So we have to step down the power and then continue the procedure. And we have to avoid the 3 or 9 o'clock position to avoid the damage to the long posterior ciliary nerves and vessels. And we have to avoid the places where the previous trabeculectomy has been done. So how to optimize a precise placement of probe using the long duration and longer duration, low power and avoiding the pop sound, we will get the good outcome. So these are the various studies has been done to 2000 to 2019 and saw that continuous wave CPC produced the good IP control from 7 to 25 mg and the IP reduction from 29 to the 60%. The mean reduction IP from 0.2 to 1.93. However, this is a good procedure. However, this procedure was associated with vision threatening complications like hypertonic, prolonged inflammation, loss of vision, and phthisis bulbi. So there's a new laser coming recent time. New laser coming is called the micropulse and has become popular and increasingly being used for glaucoma with good vision. So what is micropulse? It is a technology that finally controls the thermal elevation by chopping a continuous wave beam into the repetitive sort. So here we can understand this is 33.3 duty cycle. That means the energy is delivered in micropulse only for the 0.5 millisecond. Then there is a resting period of 1.1 millisecond. And then again, energy delivered from the 0.5 millisecond. Thus, the micropulse laser achieve the targeted tissue damage and decrease the damage to the surrounding tissue. So how to do it? It can be done at the peribulbar or subtensional anesthesia, and it needs the coupling agent. So this probe is showing the generation 1 probe, and this is the generation 2 probe. So just to identify, this is the bunny-like projection is presented in the generation 2 probe that we have to keep in limbus. Generation 1 we see in the video. So this is the power setting we have to keep around the 1600 to 2500 milliwatt and 50 to 80 millisecond. These power setting all depend upon the eye and the preoperative IOP. We can change it. So this is the surgical video. So after putting the peribulbar or retrobulbar block, we have to hold the probe like pen-like position, and we have to apply a lot of the viscoelastic around the limbus, so it will be easy to the sliding movement around the limbus. And the speed has to be little slow. It all depends on the how much duration you require. Usually we do for the 80 seconds for the each hemisphere. So the post-op regimen, we have to keep the steroid antibiotic dose 4 times a day for 4 weeks and tapered, and cycloplegic for 1 to 2 weeks. And anti-glaucoma medicine has to be continued. It has to be tapered according to the level of IOP. So what is the problem with micropulse CPC? This cost is a big challenge for micropulse because single probe is costing 25,000 rupees, and it's activated only for the 90 minutes. So make it the cost effective, we have to pool the cases, 3 to 5 cases, then we can do. If more than that case we do, the efficacy has been gone down. Apart from that, there's a mild inflammation and fibrin reaction, that is go with the steroid. It's not a major problem, but major concern about the micropulse, 20% of the patient have the vision loss in 1 to 2 lines, and some patients experience the pupillary dilatation for 4 to 5 mm, and few patients report the epithelial haze and neurotopic keratitis. However, the only few cases have the corneal detachment, but they are most of them are the self-resolving. So these are the studies has been done, and they come summarize the micropulse has good IP control, but this IP control is much less than the continuous wave. It is 6 to 17 mmHg average, and percentage of IP reduction is at 27 to the 46%. And mean anti-glaucoma medication reduced from 0.5 to 0.16. We did one study at our center, it's a prospective non-comparative interventional trial. We recruited 56 consecutive refractory glaucoma patients who underwent micropulse, and we usually keep the standard setting for the 2000 millisecond and the 2000 milliwatt for the 80 second for each year. And we find out it's a good IP control. IP dropped down from 35 to the 17 mmHg at the 6 month, and the percentage of IP reduction was 43% at the end of 6 months, and we achieved the good success rate 6 months around the 87%. So the various studies have shown POG have the better outcome, and the higher power and the lower baseline IP have shown the better outcome. So coming to just to summarize, micropulse CPC is a safe and effective alternative to continuous wave CPC, can be used in moderate and advanced glaucoma with good vision. Micropulse may reduce the need of medication, but complete success unlikely. Fewer complications than CPC, currently not recommended as a routine primary therapy. Thank you for patient listening.
Thank you, doctor. That was a very thorough talk. Murli, you take a question, or shall we go on to Dr. Shushmita? Because we are running late.
I just wanted to ask Dr. Devendra Maheshwari as to whether you have
Dr. Shushmita, you
repeated
can share the screen.
micropulse cyclophotocoagulation, and if so, how many times is the maximum that you have repeated? In case the first MP TSCPC failed to control, have you repeated this cyclophotocoagulation? What is the maximum number of times that you have repeated?
We repeated only 3 times till now. We have the few patients. We don't repeat more than the 2 times. Total three micropulse we have tried in one patient. Apart from that, if fails to convert, I think they need the other procedures.
Okay.